từ đại học, đến từ bệnh viện, đến khoa truyền hình ảnh, bệnh viện Cựu chiến binh Tài Trung, Đài Loan. Hiện là chủ tịch hội điện quang can thiệp của Đài Loan, sẽ báo cáo một cái bài chủ đề về cái nút mạch truyền thống so với nút mạch Microsphere, cái vi hạt điều trị ung thư biểu mô tế bào gan. Xin hãy bắt đầu.
Good morning, everyone. It's my pleasure to be invited to Vietnam Society of Radiology and Nuclear Medicine to share my experiences of traditional versus microsphere embolization for HCC. I'm B. Zhang, currently serving as the Director of Radiology Abdominal Imaging Department in Taichung Veterans General Hospital in Taiwan. In my 10 years of experience as an attending physician, I have handled many difficult cases of CTAs and DAPTAs. Also, as a board member of the TSIR, it's always been on my heart to devote my times to educate and groom the next generations of young talent in interventional radiology. I hope that my sharing today will inspire more young doctors. As we all know that TACE treatment is done by chemotherapy delivered in high concentration to enhance coagulative tumor necrosis. And then we will add some embolization agents to get arterial obstruction that can cause ischemia and resulting in tumor necrosis, thereby reaching a high rate of objective response. Also, we have to be aware that perfusion to uninvolved liver is maintained by the portal vein and permitting selective targeting of the tumor. So, liver function is really important when we carry out TACE treatment. And the benefits of TACE in intermediate HCC. As we know, TACE is the most widely used treatment for unresectable HCC, especially for stage B, to produce survival benefits and a favorable response without adversely affecting hepatic functional reserve, so we can reserve the liver function and reach liver control. Lencioni had published a paper in 2016 indicating that objective response rate can reach 52.5%, and the overall survival rate in 1 year is 70%. And let's move on to the comparison of DTACE and CTACE. The DAPTACE is also known as the DAP.TACE, and it uses drug-eluting beads as microspheres. And for CTACE, we usually use the Lipido with chemo agents such as doxorubicin or epirubicin, and you added some gel foam to reach arterial embolization. And for preparation, DAPTACE is more consistent and more easily reproducible because for CTACE, we usually use a non-standard procedure that is dependent on the operator. And for drug release in DTACE, it is sustained because the release of the chemo agent will last for about 2 weeks. As for CTACE, it releases drug rapidly and can only be sustained for maybe less than 30 minutes before the oil and chemo agent separate. This means that it will increase the side effect. And for the material used, the drug-eluting beads stayed permanently, but for the gel foam is temporary, which will regress within 2 weeks. For particle size, eluting beads is about like medium size, while Lipido is in small size, and gel foam cubes are in large size. For catheter positioning of the treatment, most of the time the G-TACE needs to be in segmental or subsegmental superselection, while for C-TACE, we can go with lobar or subsegmental or segmental superselection. And don't forget that the injection rate for DEP-TACE should be very slow to make sure the drug-eluting beads can go into the artery smoothly. And for embolizing the vessel, when using DEP-TACE, we usually embolize the artery. But for C-TACE, to reach a complete treatment, we usually embolize both the large artery and the portal vein. Also, remember the endpoint for DEP-TACE should be near stasis, whereas C-TACE should be complete stasis of the vessel. For the dose of chemo agent used in DEP-TACE, we can use up to 2 vials, meaning 150 milligrams of doxorubicin or epirubicin. But for C-TACE, we usually only use 10 to 50 milligrams of chemo agent. Let's take a closer look at DEP-TACE and C-TACE. You can see that the drug-eluting bead is medium size and usually ranges from 100 to 300 micrometers, while Lipiodol is in small size and gel foam is larger. But yttrium 90 is much more smaller, about 30 to 35 micrometer. So don't forget that the size of the hepatic microvascular bed, because the terminal of the hepatic arterioles and terminal portal venules are within a diameter of 15 to 35 micrometers. So it's quite safe to use drug-eluting beads for the TACE treatment. The key is to choose the size that is larger than that of the microvascular bed to avoid complications. In catheterization, we should avoid catheter wedging because if not, we will have the reflux of drug-eluting beads and complicated the procedure. Most of the time, we do the embolization selective. For 2 to 3 segments or superselections for subsegment. We can perform superselection, which means the curved catheter is positioned at the subsegment of the liver. And for ultraselection, it means that we usually reach the tumor-feeding artery. And for the embolized vessel, when performing DEP-TACE, we only embolize the hepatic artery, and we cannot see the Lipiodol retention into the tumor. But when we use C-TACE, we can see we usually embolize the hepatic artery and also the portal vein, and we can also see the Lipiodol retention in the tumor and the portal vein since the Lipiodol is radial packed under the fluoroscope. Have you ever wondered, is DEP-TACE more effective than C-TACE? DEP-TACE may be more efficacious in large tumor when the size of the tumors are larger than 5 centimeters, because for such tumor size, C-TACE is unable to treat completely. And theoretically, DEP-TACE has more sustained anti-tumor activity than that of C-TACE by releasing chemo agent doxorubicin hydrochloride consistently. And Precision 5 trial has also reduced liver damage and produced less side effect by using DEP-TACE, particularly in large tumor. Actually, there are papers that claim that DEP-TACE are much better than C-TACE, while there are also papers that claim that DEP-TACE has almost the same effect as C-TACE on response rate. So, what are the differences? you can see that for the claim that depth is better than C-TACE, the average tumor size is 6.7 centimeters. But for the claim that both have the same effect, the tumor size about half the size smaller. It's only 3 centimeters. So we can infer that when treating bigger tumors, depth may be more effective than C-TACE. So size does matter. It determines which one we should choose. Depth may be more efficacious in larger tumors that are larger than 5 centimeters. Also, it reduces the chance of liver damage and gives less side effects. Moving on to kinking criteria. The TACE usually treats intermediate stage HCC, but within the subclassification of the stage B, also known as the kinking criteria, and you can see that if the tumor size and the tumor number are less than a score of 7, it implies that we can choose C-TACE and we will observe good response. But if we have beyond or up to 7 criteria, it means that the tumor is larger or are more tumors than anticipated. Then C-TACE cannot reach an optimal response, so we have to use depth-TACE instead to produce a better response. As you can see here, we have subgroups of the stage B HCC. If the patient is stage B1, we can choose C-TACE, and if the tumor is large, then go with depth-TACE. If the patient is stage B2, the tumor is larger than 6 centimeters, we should choose depth-TACE. And if the subclass of the patient is stage B3, we have to perform super-selective C-TACE or depth-TACE. And if we have larger tumor or more tumors, then we should carry out selective depth-TACE to preserve liver function and avoid complication. And I would like to show some of my cases on depth-TACE and C-TACE. This is a C-TACE optimal scenario. You can see it's lucky day for us because the tumor is only 3.8 centimeters in length and it's located in segment 7 of the liver. Thus, it's quite simple to treat it. We use 20 milligrams of epirubicin and mixed with 4 milliliters of lipido and some gel foam cubes. Over here, you can see that the lipido filling really well into the tumor, and we can observe the portal vein clearly, so we can expect a good response for this kind of treatment. And here is another C-TACE optimal scenario. So you can see that the tumor is hypervascular and the lipido retention in the tumor clearly, and it indicated this is a good treatment too. And here is a case when we have really small HCC. In this case, the tumor is 2.9 centimeter located in segment 7, and another is much more smaller, only 0.9 centimeter located in segment 4. Don't forget, we can choose to use combine CT to assist us to reach good quality of the treatment. After carrying out combine CT, we can find a small caliber of this blood vessel supply and then do the embolization. So after using combine CT, located the blood vessel and do the super selection, you can see that the lipido reached the tumor really well, so it is a good response case too. And for the small caliber of vessels, when we are doing CTs, you can see that the vessel here is really small, and we have done the test for 4 times, and we do the selection for each vessel to make sure that we can read the blood supplying vessel of the tumor, and we choose a burn type microcatheter to this treatment. And after the treatment, you can see the lipoidal retention. And here you can see that after the treatment, the lipoidal retention is quite well. So this is also a complete response case. Moving on, here is the case of right inferior phrenic artery. We also performed CTs to reach the vessel and to embolize the tumor. So we can easily choose the blood supply of right inferior phrenic artery, and you can also see the lipoidal retention. Let's move on to my depth test cases. We did depth tests on small tumors, but you can see from here that we are treating this small tumor. We usually first do the DSA to identify the tumor stain, and then we did cone beam CT to locate the blood supplying vessel. Then we added drug-eluting beads to the specific vessel of the tumor, and we received a good response from this procedure. So you can see after the depth test treatment, we observe tumor necrosis, but we don't see lipoidal retention. Same for the small tumor. From a medium-sized tumor, we choose depth test because this patient has poor liver function. The bilirubin is up to 2.5. So after several treatments, the bilirubin didn't increase, meaning the liver function can be preserved instead of being damaged. So that's why I choose depth test for this patient. And for the larger tumor, we have this HCC in 12 centimeter long. And after 2 times of depth test, using 2 vials of 100 to 300 micrometer of DC beads, you can see the vascular lake formation. And I added a little bit of lipoidal to control the vascular lake. After the imaging follow-up, we observed the lipoidal retention into the vascular lake, but good tumor necrosis. And for this case, it is a very large tumor. It's up to 24.6 centimeter long. Over here, we can see that the whole right lobe is occupied by the liver. We did 2 times of depth test, and after the depth test, we observed decrease of the tumor vascularity, and this is a partial response of the tumor. To conclude, there are indicators which we can look out for CTs and depth test. And the most important indicators are the tumor size, the number of the tumor, and the liver function. And for small size, I recommended to use small size of microspheres or simply just use CTs to reach a more objective response. As for medium size of tumor, around 3 to 8 centimeters, I recommended using depth test as it produces a better outcome and less side effect. For large HCC, which are larger than 8 centimeters, we can opt for depth test as well, because we can get better response while creating less side effects. And I hope my sharing brings some insights to your practice. Thank you.